Thank you much, Chairman, ladies and gentlemen. I have unfortunately a little bit stronger German accent than Michael, although I'm living here for quite some time now already. It's a pleasure for me to talk to you about the role of the heart team in the context of TAVI and about patient assessment for treatment of aortic stenosis. Well, you all know that the partner trial was the first randomized trial where randomization was done against medical treatment and against aortic valve, surgical aortic valve replacement. And the latest presentation available online already from the cohort B indicates that inoperable patients have a 25% survival benefit by 2 years after the transfemoral implantation compared to medical treatment. And that is, of course, important data. And only 4 patients need to be treated to save 1 patient's life. And high-risk patients were randomized between transfemoral, transapical, transcatheter heart valve implantation versus surgical AVR. And you see the picture is a little bit different with 2-year survival mortality quite similar between the 2 groups. There are some other differences between the groups which I will not go to in more detail. However, it is important to recognize these were inoperable and high-risk patients. So if we come to the assessment of patients, if we come to the heart team, most important it is that we identify patients who face a high risk for surgical aortic valve replacement to identify the right cohort of patients. And of course, we all have more or less an understanding about what a high-risk patient for aortic valve surgery is. And most important in this context are definitely severe comorbidities. We have heard already about the pros and cons of scores, but unfortunately they describe some of the morbidities which we measure at the moment. Frailty plays a particular role, and particularly immobilization plays a particular role for the outcome of conventional surgery. There are certain challenging, surgical challenging subjects, such like calcified ascending aorta. Surgical access can be more difficult, which can increase the risk. And there are, of course, things like severe respiratory disease, which may make patients even inoperable. So therefore, it is interesting to see how the definition of high risk was done in the partner US trial, and it comes not down to any kind of scores or any kind of certain hard factors, but it was an assessment done by an interventional cardiologist and a cardiac surgeon, and an SDS score of more than 15 was just used as a guideline. And patients who were seen to be inoperable if their expected mortality from surgical AVR was expected to be more than 50%. And high risk if their expected mortality from surgical valve replacement was seen between somewhere of more than 15% and but less than 50%. So quite a high expected mortality based on the judgment of the interventional cardiologist and the cardiac surgeon. For UK funding, we have seen already the reality we are facing at the moment, and the logistic view score is still seen by the commissioners as some kind of cut-off point, and also some special comorbidities of patients. That was the reason, or that explains why heart teams play such a big role. And I have to say that since 2007, when we started our experience at King's, we at King's Health Partners have always had strong heart teams. Our heart team consists of interventional cardiologists, at least 2 surgeons, cardiac imaging specialists, anaesthetists, care of the elderly consultants who are particularly helpful to give some kind of common sense evaluation of the patient's prognosis, but also nurse specialists and research nurses, because it's not only enough to do these procedures and to follow your patients, but it's also important to assess your results and make them available to the outside world, because that's the only way how people will understand the role of surgeons in that context, and how, for example, rumors about certain access approaches or certain type of therapies can be addressed and managed. Most important questions for the heart team, from my point of view, are focused on the patient itself. So, for example, if you're running a heart team, you see a lot of patients who are actually referred to do not have symptomatic severe aortic stenosis. So that's something important to identify in the beginning. The high risk for surgical aortic valve replacement needs to be identified, and in general, it needs to be made sure that patients have a reasonable prognosis, whatever kind of procedure they undergo. And of course, particularly dementia and malignant disease plays a significant role in this kind of assessment. For the TAVI itself, it's important to find out, is a patient technically feasible? Is it technically feasible with only particular access routes, or in general feasible? And so the team needs to have a clear understanding about what kind of challenges during the implantation we are facing, and also how they can be addressed with the right approach. And of course, then it comes to the procedure itself, and as Michael pointed out very nicely, there is not only a part for the heart team in assessing patient and planning the procedure, but also in performing the procedure. And from my point of view, the ideal way to develop a heart team is that surgeons and cardiologists work together right from the beginning, that there is a focus on transfemoral from cardiologists in the beginning, transapic from surgeons in the beginning, but then over time you also have to swap over, and you have to participate or you have to develop your expertise with the non-surgery or non-cardiology approach, because that enables you then to develop a more objective type of assessment and view of the individual procedures. In terms of preoperative diagnostics, we focus heavily on assessing quality of life of the patients, and also assessing their mental status. There are cardiac diagnostics which have been already demonstrated, coronary, femoral and subclavian angiogram, whatever you need for your planned procedure are important to have. 3D echo or cardiac CT, from my point of view, is vital, because it's very nicely shown that cardiac CT is heavily superior to 2D echo imaging. But if you have 3D echo imaging, that overcomes that shortage, and the 3D assessment of the aortic root is important. And in that context, it's not only important to focus on the annulus, from my point of view, but the size of the valve you want to implant, from my point of view, needs to be addressed to the annulus of the aortic valve, but also to the size of the sinusoidal junction, to the quality of the sinusoidal junction in terms of calcification or other kind of malformation, and also to the left ventricular outflow tract. If you have your hypertrophied septum, for example, that has an implication of the size of your valve maybe as well. There's a number of non-cardiac diagnostics one need to address as well. Aortic CT plays a particular role here. Most important from that point of view is to identify calcification in the iliofemoral arteries, tortuosity of the iliofemoral arteries, and size and caliber of the arteries, and cardiac Doppler lung function tests. You also need this information to come up with a proper assessment in terms of potential risk of the patient for surgical aortic valve replacement. In general, TAVI inclusion criteria have been according to the early trials on TAVI procedures, and there is no doubt that high-risk patients can be considered for TAVI, and a logistic Euro score of more than 20, that's usually what Edward Sapien valve users use, and more than 15, that's more what CoreValve users use, is seen as some kind of a guideline. With an STS score of around more than 10. Severe aortic stenosis is important, and the challenges of gradients and assessment of aortic valve area have been mentioned already. It is, of course, important that particularly for this age group of patients, that patients should be symptomatic, because all the evidence we have is only on symptomatic patients of that age. And then there are, of course, particular medical conditions as calcification of the ascending aorta or radiation treatment of the sternum, which make the surgical approach more challenging. However, if one looks at the general TAVI exclusion criteria, which have been mentioned in the past, it is quite interesting to see that some of them are not existing anymore, or some of them are not absolute anymore. And I have highlighted that with the different colors in here. And you see, for example, that severe deformation of the chest was a contraindication for TAVI in procedures right in the beginning. Nowadays, it's not a contraindication anymore because we have more access approaches developed over time, and we will hear more of this in the coming talks. In addition, there are some highlighted in yellow. High-risk patients, for example, with impaired left ventricular function, that's not a problem anymore. Coronary artery disease is something where we know that sometimes even if it's untreated, it does not play much of a significant role. And bicuspid aortic valves have been mentioned. They have their challenges, but some of these patients are still suitable, treatable with a TAVI procedure. On the right-hand lower side corner, you see the relative contraindication for the transfemoral approach. A femoral iliac artery diameter of less than 6 millimeters is definitely seen as something which is difficult to deal with either device on the market. But however, atheroma or tortuosity of the iliofemoral arteries plays less of a role than it has been in the past. So therefore, all this information then can be used for the HRT meeting. It is important, nevertheless, that the decision on the patient is not only done based on the outcome of the diagnostics, but also on the personal assessment of a patient. From my point of view, it's important that one has that one spends some time of talking to the patient, maybe sees how the patient mobilizes, maybe gets a better idea and background about what the patient really wants and needs. However, if the patient is identified to be low risk for aortic valve surgery, then the patient should have surgical aortic valve replacement. If they're identified to have high risk for aortic valve surgery, then there are, of course, different options. You may find the patient too sick for anything, and we have heard already about the problem with this. I think particularly patients with dementia, particularly patients with immobilization, and particularly patients with where malignant disease plays a role need to be assessed carefully and may need only medical treatment in the future. You may have the patient who is clearly unsuitable for TAVI because of anatomical features, and these patients definitely need to then be reconsidered for surgical aortic valve replacement, because what we know from the partner trial also is that patients with high risk for surgical aortic valve replacement do quite well indeed. And there are the patients who are ideal for a transcatheter valve implantation, which can be considered for a TAVI procedure, and based on the experience in the heart team, can be looked at from all sides in terms of what kind of procedure can be done. And there is a patient group where you are not 100% sure how much they will benefit from the procedure, and in these patients, of course, balloon aortic valvoplasty may be a tool which can prove the concept of a future transcatheter valve implantation. In terms of outcomes of the heart team discussions, in terms of what kind of TAVI approach we use, we have at King's quite a long experience with that. This is data from last year. Now we have close to 500 procedures performed at King's Health Partners organizations, and what we find is that we had in the past around 50% of patients going in the transfemoral direction, 45% in the transapical direction, that was last year, and others only 5%. The other group is slightly increasing, and that is due to the developments Vinny Babat, who will speak later on the transaortic approach, has done with transaortic access. And of course, he has delivered favorites the transaortic axis a little bit more than the transapical axis. There is no hard data on that, but that's the reason why our other group is increasing now slowly, and we will need to see how the different non-transfemoral axes compare to each other, which is of course something we need to focus on in the future. So that is the reason why most of the heart team discussions are about transapical and transfemoral axis. And for transapical, it's of course important to recognize that there are only limited restrictions due to access, that it has a very good direct digital control of the device, which is particularly helpful in patients with septum hypertrophy or post-mitral valve replacement. And for the Edwards sapien valve, it is the axis of choice for valve and valve treatment of failing bioprosthesis. The transfemoral approach, nevertheless, is our first access approach, and is our default approach in patients, and that is mainly due to the fact that particularly postoperative pain is reduced after the implantation, and that is, of course, of particular help in patients with severe respiratory disease. However, the decisions are not often easy to make, and that's the reason why I have a few examples of patients to illustrate how the discussions sometimes go. And for example, this year is a 92-year-old lady who was referred to us with breathlessness and diagnosed with aortic stenosis. And as you can see, she had long-standing COPD and a severe impaired lung function. But she also had severe peripheral vascular disease, and the diameter of the femoral artery was 6 millimeters. And as you can see, she had very heavily tortuous arteries and heavily calcified arteries, and a logistic Euro score of 26%. However, due to her severe respiratory impaired function, we decided that she would be an ideal candidate for a transfemoral procedure as long as one would be able to place it safely. And being able to have the newest equipment on site, we therefore, after we made sure that she has severe aortic stenosis with a mean gradient of 64 millimeters mercury and an aortic valve area of 0.4 square centimeters, I think there was no doubt on that. With that basis information in mind, we decided her to undergo a transfemoral TAVI procedure. The reason why we were able to do that was that we had the E-sheath already on site, and the E-sheath is a 16 French sheath, so the smallest you can have for the insertion of the device, and it takes the Novoflex device, so the delivery device of the Edwards Sapien valve, and we decided to implant a 23 millimeter prosthesis. As you can see, the implantation was quite unsuccessful. The more challenging thing was to get the device into the aorta, and I think it was helpful that she was a quite short lady, so the tortuosity, which took a lot of length of the device itself, was not a problem in terms of total length of the device. The valve was inserted without any problems, and the postoperative result, hopefully we can see here as well. She then had a proper echocardiographic assessment directly after the procedure, because we do all our procedures with 3D echo guidance. You see there's a little bit of parallel leakage. She had a mean gradient of 4 millimeters mercury on the valve. But most important in these patients is, of course, that after you take all the devices out, you make sure that the arteries are intact and you don't face any kind of problems from dissection in the iliofemoral arterial tree. She was then discharged home 5 days after surgery after an uneventful postoperative course. Another area where you heavily depend on the heart.
Olaf, can we need to move on to the next session.
Yeah.
If you don't, sorry about this.
I have 2 slides.
That's
we'll
okay.
finish
That's
2
fine.
slides,
Sorry.
please. So another area where you're heavily dependent on the cooperation with your heart team is, for example, valve-in-valve procedures. You can see here there is no way that you can see the aortic valve, and therefore the implantation has to be done with the 3D TOE guidance, and that was done successfully. And of course, valve-in-valve procedures are not only something for aortic valves, there also needs to be done another heart valve prosthesis. This here is a mitral valve prosthesis, where a valve was then implanted, the 26 millimeter valve implanted using the transapical approach. And as you can see, the valve deploys quite nicely in there. It's done under 3D TOE guidance, and the valve has a normal valve function afterwards. So therefore, I'd like to conclude that the heart team is key for a successful TAVI program. But using a standardized diagnostic protocol, patients at high risk or unsuitable for SAVR are identified. The heart team needs not only to cooperate during patients' assessment, but also at their TAVI itself. And the mix of skills will enable the heart team to be technically able to perform TAVI procedures for various routes in almost all patients. Thank you much for your attention.
Any questions from the floor? Just a quick point then. You mentioned balloon valvuloplasty. How big a role is that playing in you determining patients then going to TAVI and surgery? Because we've taken a few who were first put forward for TAVI and then done the valvuloplasty and then moved them actually into the surgical cohort.
The ones we plan for balloon valvuloplasty, they are patients who are questionable because of their general condition. We have not converted any one of these patients into surgery. but we have converted around 40% of those patients into TAVI patients.
Great. Well, thank you, everybody who spoke this morning.